to meet local providers and make ourselves even more available. So our theme tonight is what's the very latest in electrophysiology, in a way where how can it serve our most common patients and give them more and give them the latest and the best. So that's our topic tonight, and I'm hoping to take us through a number of items that I think you'll find very interesting. If you have any questions as we go along the way, just holler out. We can have a nice, easy discussion. That would be super. So next slide, please. That's just a little bit about my background, if you're interested. So I'm actually from the West, grew up in southern British Columbia, a Walla Walla University graduate, and then went out east for nearly 2 decades for medical training, mostly in Montreal at McGill, including internal medicine, then cardiology at Columbia University, and finally electrophysiology in Los Angeles, and then a second year in Richmond, Virginia. First job in Spokane, second one in at Cadlick Clinic in the Tri-Cities. So that's my trajectory. Next slide. This is a newspaper article from the Tri-Cities Herald announcing our electrophysiology program. This is our EP lab. We're getting ready to do an ablation here for atrial fibrillation. This is my key staff member on the left, who also relocated from the Tri-Cities with me. The article actually featured Ms. Huggins receiving the new Boston Scientific subcutaneous implantable defibrillator, a woman with postpartum cardiomyopathy needing ICD protection. We were able to offer her that very less invasive, non-invasive solution to that problem. The article focused on that. But it was nice to get that media plug, and we are indeed up and running in the Tri-Cities, and really fast out of the gates, having had very experienced laboratory staff relocate with us to make the program possible. So I'm grateful for that. Next slide. So we are happy to assist with your patients, symptom evaluation and diagnosis. Arrhythmia patients complain about palpitations, they have heart racing, they'll experience an irregular pulse, skip beats, pauses, they'll have blackouts, unexplained falls. These are the things that we go after. We can help with device implantation and management, pacemakers, defibrillators, resynchronizing pacemakers that also have defibrillator function, or just resynchronizing pacemakers. We do a good number of these as well. And then we have a very comprehensive ablation program. Most commonly for atrial fibrillation, the burden of atrial fibrillation is staggering. We do a lot of AFib ablation. We have a very successful program. I'll highlight that. And also supraventricular tachycardias, atrial flutters, and ventricular arrhythmias, and actually a lot of premature ventricular contractions. We specialize in our ablation lab, and I'll show you some examples of all of those. I think you'll find it kind of interesting. I'll take the next slide. So let's start first of all with device therapy. Very simply, take the next slide, Cressa. Pacemakers. So when are pacemakers indicated? These are for patients with slow heart rate. When should you consider referring a patient to see us? Obviously, for any symptomatic slow heart rate, that can be from just they're going too slow, they have heart block, there's long pauses when the heart rate is otherwise regular, or if you haven't demonstrated that, how about any concerning bradycardia? You as a provider, if some patient has slow heart rate or symptoms that are suggestive enough to concern you, that's enough to refer to us to think more deeply about possible pacemaker implantation. So take the next slide. And pacemakers, very interestingly, are coming a long way, and they do a lot more than pacing these days. Very importantly, pacemakers now provide remote monitoring, that when a pacemaker is implanted, we now have comprehensive monitoring of that person's cardiac rhythm and function. Tremendous amount of diagnostic information that come to the devices now over the internet, over the phone lines that we get in advance that really help us manage our patients, help us keep them out of the emergency departments. So important to know that when we refer a patient for a pacemaker, when we implant them, that we now have them committed to a monitoring program that's really going to help with their individualized care. Pacemakers, for the most part now, are MRI compatible, so you're not denying someone an MRI when that pacemaker is implanted. And interestingly, pacemakers can even treat atrial fibrillation and different atrial arrhythmias, and I'll show you some examples of those. Have the next slide. So here's a very simple pacemaker for someone with what we would easily recognize as complete heart block. P waves marching through the QRS. And this, on this X-ray, is what I would call a perfect pacemaker implant. If they all looked like that, I would take it every time. We have a pulse generator that's very medial, won't interact with the patient's arm. You can see the two leads coming very gracefully through the veins. Here's our atrial lead, this one, curving up into the atrium, and then the lead to the ventricle riding very smoothly across the tricuspid valve, and then having a nice uptick as it enters and inserts into the interventricular septum. So a very nice implant result. That's what I like to see on every post-operative X-ray for a pacemaker. And then, like I said, pacemakers become monitors. Here's a lady we implanted. She was 90. She had dizziness, bradycardia, pre-syncope. And indeed, she did have slow heart rate. She does require an appreciable amount of pacing, but then that pacemaker is also a monitor. She comes back now with symptoms of heart racing. She's feeling dizzy again. The pacemaker can document this arrhythmia, and we can take her to our electrophysiology lab and offer her an ablation for what proved to be an AVNRT rhythm. So using the pacemakers to give us diagnostic information that help us better manage patients who have other problems that the pacemaker can help us detect. Pacemakers can treat atrial fibrillation. This is someone who came to my clinic just 2 weeks ago. Here you can see on the cardiac compass, this is 24 hours in a day, and all the black lines are the amount of time he's spending in atrial fibrillation since May of 2013. So you see a high density of atrial fibrillation. Then right at the pink arrow was his last cardiology visit, when the person referring him to me turns on the function to treat atrial fibrillation with this particular pacemaker. And you can see after that pink line, there's kind of no more atrial AFib. And what that device is able to do is detect the atrial fibrillation, burst pace into the atrium from that atrial lead, converting those rhythms into normal sinus rhythm even as they're starting. So the patient's already feeling tremendously better from the therapy he's receiving, referred to me for an ablation procedure for atrial fibrillation, and it turns out he's already being treated effectively, and we don't have to progress to that procedure. So, you know, really exciting stuff. What's interesting about our field is that the technology moves so quickly. What we can offer people really progresses at warp speed. It's exciting to be a part of, and exciting to see our patients benefiting from the technology. I'll have the next slide. So moving on in our topic, one of our major themes in electrophysiology is the problem of sudden cardiac death. Person is well, next thing you know, they're dead on the floor. 350,000 victims of sudden cardiac death per year in the United States. So it's a tremendous problem. And for people who are going to have sudden cardiac death, a ventricular arrhythmia that is life-threatening, obviously we'd like to have those patients implanted with an implantable defibrillator so that when those rhythms do occur, the device can recognize those rhythms, try to forcefully pace them out of them. If that doesn't work, charge up, deliver a shock, which can be life-saving. The problem is our guidelines for implantable defibrillators do not predict very well all the people who are going to actually experience sudden cardiac death. So this iceberg represents all the sudden cardiac death victims. And the part of the iceberg that's below the water are those people who will have an arrhythmic event, probably an arrhythmic death, who fall outside the guidelines for ICD criteria. The iceberg above the water are those who fall within the guidelines, and that little red circle is the group who are within the guidelines for an implantable defibrillator who actually receive an implantable defibrillator. So compared to the magnitude of the problem, we can see the patients who actually receive this therapy is relatively small. So we can say that the guidelines fail the majority of sudden cardiac death victims, and then we have to acknowledge that providers perhaps fail the majority of patients who do meet guidelines for ICD protection. So I'll have the next slide. So who should be considered for an implantable defibrillator? We think of primary prophylaxis. This is somebody who's never had an arrhythmia. Nevertheless, they have either an ischemic cardiomyopathy or a non-ischemic cardiomyopathy. Their ejection fraction is low, less than 35%. We know they're at risk, and they should be considered and probably referred. Secondary prophylaxis is obviously anybody who's had a ventricular arrhythmia, maybe a sudden cardiac death event. They deserve protection should that ever happen again. So these are the two groups that we really think about and who do warrant strong consideration. So here is a Boston Scientific defibrillator as secondary prophylaxis in a 59-year-old male who suffered a sudden cardiac death event after applying testosterone patches across his body in an attempt to feel more masculine. He did have an arrhythmic event at home in his bed. His wife had to give him CPR. We brought him into the hospital, shocked him a number of times to finally settle him down. And then as a part of the discharge process, you need an implantable defibrillator to protect you from this happening again. So what we see is it looks very much like a pacemaker, only it's bigger, more battery power. And the lead, here we see a single lead passing into the ventricle, and that thick coil on the end of the lead that you didn't see on the pacemaker, that's the shocking coil. So should that device detect a rhythm, that device can charge up, and between that coil and the device itself deliver a vector of shock energy able to reset your rhythm to normal. And that's the basic function of an ICD. A very new technology, also a Boston Scientific product, is this new subcutaneous ICD. Well, one of the barriers to implants of ICD, we believe, is a history of device component failure in certain manufacturers and certain products, which have caused a certain amount of morbidity for patients who have ICD protection. A very new and very interesting solution is the subcutaneous ICD, where now no longer is the device inside your body passing through your vessels into your heart. The device is sitting entirely outside of your skin, or under your skin, outside of your chest cavity, with the defibrillator lead now coming under your skin, up the front of your sternum, but being completely external, able to provide that ICD protection that the more traditional ICDs always provided in the past. So a brand new technology that is very exciting and has the possibility of really revolutionizing ICD care. Who is a good candidate? It's someone who doesn't need a pacemaker, because ICDs can also act as pacemakers, and it's somebody who has a narrow QRS complex. And we'll see, so for the chance of them ever needing resynchronizing therapy, the chance of that is low. They're excellent candidates. I'll just take the next slide. So we're doing some rearranging in the room here. So here's an example of one of our implants. 55-year-old female, young. You don't want to subject to decades of intravascular hardware. Mild coronary disease, diabetes, ejection fraction 30 to 35% despite chronic optimal medical therapy. So she's at risk despite good medical therapy. No reason to believe she'll ever need a pacemaker. Her QRS is narrow, so her conduction system is very normal. We implanted this subcutaneous defibrillator in December of 2013. So you can see the components. The device sits on your side, right along the apex of the heart. On the lateral x-ray, it's about mid-axillary, so it's really sandwiching the heart muscle. And you can see the defibrillator lead running anteriorly up the sternum, just under the skin. And that shock vector can then sandwich the heart. When it detects an arrhythmia, charge up, deliver that ICD therapy that can indeed be life-saving. So this is the new subcutaneous defibrillator. It's just an extremely exciting technology that's now available to us. I'll have the next slide. Again, when a patient has a chronically depressed ejection fraction, despite your best medical therapy, despite revascularization, strong consideration for ICD protection should be considered, and I hope you do make the referral to us. Give us a call anytime you want to discuss someone who you think may benefit from an ICD. Let's move on to a very exciting part of an exciting extension of ICD therapy, and that is this business of resynchronizing pacing. I regret implanting an ICD in a patient because I have to tell them the device probably will not make you feel any better, but it's going to protect you in case something catastrophic happens. That's about as exciting as having life insurance. You know, when you have a resynchronizing pacemaker for a patient who has heart failure and conduction system delay, you can say, we can offer you a resynchronizing pacemaker. It will completely overtake the electrical function of your heart, should increase the synchrony of your heart contraction, make you feel better, help the heart recover, help you live longer, in addition to providing you with ICD protection. And this is the business of CRT, or cardiac resynchronizing therapy. So again, you have that low pump function, and now you have bundle branch block, so conduction delay. And like I tell the patients, I say one side of your heart gets the signal to start contracting way before the other side even knows to begin, and as a result, it's very uncoordinated, and that reduced pump can't synchronize itself to even perform effectively at that reduced level, and that's contributing to your symptoms of shortness of breath, fatigue, can't lay flat, etc. By offering the resynchronizing therapy, again, we can treat that disease process at a fundamental level and start to reverse those effects. So we can do that with defibrillator capacity or without defibrillator capacity. And I'll just take the next slide. So here is a classic case. We have a patient who has a non-ischemic cardiomyopathy, pump function is 20%, deserves an ICD, but then we see on the ECG there's big left bundle branch block, and the QRS is 174 milliseconds, so beyond 130. And you say this person can also benefit from resynchronizing pacing. And now we see, in addition to that ICD system that you recognize, on the lateral wall of the ventricle, you'll see that extra pacing lead snaking its way through the coronary sinus and the cardiac venous system to sit on that lateral left ventricular wall, where it can pace that lateral wall at the same time it paces in the right ventricle and resynchronize the pump. So they come in with a big left bundle, they leave with a nice right bundle, and that's a beautifully resynchronized ECG, and we expect these patients to really benefit clinically. Can have immediate responders coming off the procedure table, and often we'll see good recovery of the ejection fraction over time. And for those patients who don't respond as briskly, we can hope and trust that their ventricle will be supported and will sustain itself for a longer period of time, and we can improve their mortality. So that's device therapy. Something we love to do, expose ourselves to a lot of fluoroscopy to get those results, but it is rewarding. We can talk about arrhythmia therapy. Very common arrhythmia that we're all dealing with, always confronting every day is atrial fibrillation. And we have so much to offer our AFib patients now. A word on the relevance of AFib. We know that 2.2 million people in the United States right now have atrial fibrillation. That might exceed 12 million by 2050. There's an increased risk of ischemic stroke by a factor of 5 for AFib patients. That's 36% of strokes in age 80 to 89. We know strokes in AFib patients are more disabling, more likely to recur or to be fatal than strokes in other contexts. We know that AFib can exacerbate heart failure. And finally, it can cause symptoms, specific symptoms of palpitations, feeling out of rhythm, irregular. Patients actively complain about those. And then very importantly, non-specific symptoms of fatigue. People feel wiped out all the time because of their AFib. You know, if your heart goes 100, 120 beats a minute all the time, you're going to feel like you're running a marathon all the time. And if you do that day in and day out, you know, over long periods of time, you're going to have a level of fatigue superimposed on your life that doesn't need to be there because of the atrial fibrillation. So this is kind of an exciting result. This is our EP lab at Cadillac, and we had an invited article in EP Lab Digest, which was just published 2 days ago. So there's a slide about our ablation program for atrial fibrillation at Cadillac as an educational tool for the EP community, explaining some of our unique approach to this procedure and some of the ways I think we use the technology for ablation very creatively to get really exciting results for this particular procedure. So what actually happens when a patient is referred for AFib ablation? I'll just take you through the thought process and the preparatory process so we can see what happens for that procedure. We'll see our patient in consultation. We want to know, first of all, is the AFib paroxysmal or is it more persistent? Clarify what exactly the symptoms are. Has that person tried an antiarrhythmic drug, and should one be considered before we proceed to an ablation procedure? We look for comorbidities, mainly obesity, sleep apnea, some valvular heart disease, any coronary disease or peripheral vascular disease, very important. We need an anticoagulation strategy, so CHADS and CHADS-VASc scores. We have warfarin, Xarelto, Eliquis, Pradaxa, all these agents available to us. Even if you're only on aspirin now, post-ablation, you need a stronger anticoagulant for at least 3 months. So people need to be committed to that before they start. And then finally, what we'd like is some sort of monitoring strategy. How well did we do? Did the ablation actually get rid of the atrial fibrillation? If you have a pacemaker or a device, that'll tell you. If you don't, I use a lot of these implantable monitors, again, a very new product from Medtronic that can, be in a minimally invasive way, really quantify the burden of atrial fibrillation that any one individual is experiencing. And I'll show you that. So we have the patient. The first thing we want to do, if they don't have a monitor, is implant a monitor. Get 4 to 6 weeks baseline of their AFib burden. We do a pre-procedure CT to get the size and shape of the left atrium, because that's the chamber we're going to be working in. We'll stop any antiarrhythmic drug they're on 4 to 6 days in advance, hold the blood thinners, undergo the ablation procedure under general anesthesia, reset the loop recorder at that time to start recounting the amount of AFib they may have after the procedure, restart the blood thinner, restart the antiarrhythmic drug. The patient walks out of hospital feeling fine on post-procedure day 1. We'll continue the antiarrhythmic for at least 3 months and then stop it if there's no AFib. If there's still some AFib, appreciable AFib, we'll continue for another 6 and reassess, and then make the decision about how long the anticoagulation is indicated, and then return the patient to the referring doctors. For anyone who's concerned, we're not in the business of scalping patients. We tend to have too many patients. So the patient, we really want to send back to the referring with our management plan and follow up on an as-needed basis. So just a word on AFib monitoring. So this is a new Medtronic product, just approved by the FDA in February 2014. This can slip under your skin, sits over your chest muscle, can add up every whiff of atrial fibrillation that you're having. How many episodes you're having, how long they're lasting, when they stop and start, how fast your heart goes during AFib, how fast your heart goes when you're not in AFib, provide you with all this diagnostic information. The top monitor was what we had prior to February, an excellent device. It's about the size of a USB stick. And now we have this smaller one about the size of a paperclip. Can implant it in about 2 minutes, feels like 30 seconds. Patients can go home 30 minutes after the monitor is implanted, and we will absolutely know everything about their atrial fibrillation going forward. So here we actually performed the first implant of this device in the state of Washington on March 24, and this is really the essence of the technique. We have this trochanter delivery system. You slide that subcutaneously and then use an injector system to push that monitoring device below the skin. Remove the trochanter, hold pressure, surgical glue, and they're good to go. So very superficial, non-invasive. Should they ever get in trouble from the monitor, it can very easily come out. So it's a low commitment from the patient in terms of cosmetics and invasiveness, with a high rate of return on the information that we receive. And when you present it to patients, they're actually very excited for this technology. AFib is smoke and mirrors. How much do you actually have? How fast does your heart rate go? We know it in the office. We don't know what happens when you're out of the office. How much is there on average? Is it bothering you at night? We can't, it's really hard to know unless you commit someone to external monitoring. And we all know how clumsy that is. And even when you do it, you only get the data for the time the patient's wearing it. What happens when you change therapy? Well, you'd have to remonitor to know. Very challenging. Got it.
As far as insurance is concerned, do they have to have a certain amount of syncope or a previous episode, or for them to cover something like this versus external monitoring? Or?
That's a very good question. I have not received pushback on this particular device. It's a good question. I'll often start with an external monitor. When I know it's an AFib patient who I'm taking to ablation, I'll go straight to the loop recorder. I just document why I'm doing it for management of this arrhythmia. Goal to prove symptom control, reduce emergency room visits for atrial fibrillation. I haven't received pushback.
I noticed that you mentioned anti-arrhythmias before going to an ablation, but I didn't see anything about cardioversion. Are you still
I don't require cardioversion. If somebody has symptomatic atrial fibrillation, I will say our guidelines encourage us to try you on an antiarrhythmic to control your AFib first, and I'll really try to get someone on have a reasonable trial of an antiarrhythmic medication, and then should they fail that, either because it doesn't provide them control, adequate control, or they can't tolerate it, then I'll say we can switch, or we can offer you an ablation procedure. But I don't say you have to have a trial of cardioversion before we go that route. Because even a highly symptomatic paroxysmal who's going in and out of the arrhythmia anyway, if the drugs can't control them and they're miserable from it, we have the justification to offer them something more. Yeah, that's kind of how I look at it. So again, here's the link monitor. This is in our original implant patient, immediately post-procedure and then at 2 weeks. And you can see how minimally invasive that device is. Very nice for young people, particularly young females, who need cardiac monitoring because that device is so minimally invasive and the scar is so innocuous. And this is the data we get. We get an electrogram amplitude on 0.57 millivolts the device records, and you can see that electrogram. Recording that every beat of your heart for the next 3 years. It's 1,000 Holter monitors sequentially. And we can program that device to detect and quantify atrial fibrillation, and it will do that by a mathematical measurement of the irregularity of the ventricular activation. It's just the same way we would interpret an ECG, and studies have shown that it's identically as good as a Holter monitor in quantifying AFib. So let's just look at a case of AFib quickly. We have a 65-year-old man, structurally normal heart, prior DVT. He has AFib causing shortness of breath and fatigue, uncertain burden. So we implanted the Reveal monitor on March 2013 to guide his AFib therapy. We offered him flecainide, reduced his AFib burden from 20% to 0.7%. However, he's feeling blurry vision. He wants to stop flecainide, and he doesn't want to try another antiarrhythmic. So we say, fine. We stop the flecainide. Months down the road, he transitions to persistent AFib, and we can advise him, we're losing control of this. If we're ever going to rein this in, we need to consider an ablation procedure soon. So with the help of the monitor, quantify what that patient is doing and really offer patient-specific therapy that's most appropriate for that individual. Let's take the next slide. So here we go. So here we are in April 2013 all the way up to December 2013. And you can see on the very top plot, those little black stubby bars are the atrial fibrillation burden every day. And you can see in the presence of flecainide, he has really none. Then he stops his flecainide and continues to have none until the spikes start to appear. So that's the paroxysmal AFib coming back, and then it just goes solid. So now he's in persistent atrial fibrillation. And you can advise this patient, if you don't want to try another antiarrhythmic drug, really the only solution for your AFib is an ablation procedure, and help him make a very informed decision about his care. So we go to the ablation procedure. First thing we do is a cardiac CT or MRI of your left atrium, because we really want to know the size and shape of your chamber, and we're going to use that in performing your procedure. So with that data, I'll take the next slide. So here's your CT. We will decompose that CT image, removing the chest, the vasculature, to isolate the left atrium with the pulmonary vein insertions. So the backbone of an AFib ablation is to ablate around and electrically isolate the 4 pulmonary veins that insert into that left atrial chamber. That's the cornerstone of the procedure. So for each individual, we want to know exactly how those pulmonary veins attach to the atrium so that we can do that component of the procedure most effectively. And then we'll actually take that image and use it electronically to guide our ablation procedure. So that's the CT image. Here we are in our lab, we're set up, we're ready to go. We have people in our control room. a couple of operators actually at the table by the bedside. The patient is under general anesthesia, so they're intubated in our lab. The first thing they know when they come in the room is we say good night. The next thing they know is that the procedure is over. In the meantime, we've done quite a bit of work. So with our catheter mapping system, up through the veins into the heart, when we move the catheter in the heart chamber, the computer system is going to recreate that heart structure by memorizing every place where that catheter has been in the heart chamber. And you can see there we've reconstructed the inferior vena cava, the superior vena cava, the right atrium. We know that most of the atrial fibrillation comes from the left atrium, so we poke across the wall, separating those two top chambers with a needle. Here we are on a fluoroscopy image with that needle pressing on the interatrial septum. You can see it on the echo image there, tenting that septal wall towards the left atrium. We poke across, place our catheters in the left atrium, manipulate the catheters throughout that chamber, recreate that chamber, compare it to the pre-procedure CT until we've reproduced it sufficiently, and then with our catheter apply cautery energy to go around each of those 4 veins and electrically disconnect them. We look for other hot spots in the atria contributing to the arrhythmia, and we ablate those at the same time. Goal to at least stop the episode of atrial fibrillation, real goal to achieve non-inducibility, and it's always very exciting for us when by the end of the procedure we can't even get atrial fibrillation started again. So I'll have the next slide. So let's take one more example. Here's a 64-year-old man. His wife worked in our practice for 28 years. He has a history of coronary disease, prior stenting. His ejection fraction is preserved, and he has chronic atrial fibrillation. So he's actually been given a diagnosis of permanent atrial fibrillation. He's sent to me, can you put in a pacemaker and ablate his AV node because his AFib is horrendous and it's just hopeless, it's permanent. So we kind of challenged that diagnosis of permanentness, implanted a monitor, started him on what's my favorite antiarrhythmic drug, and that's dofetilide or Ticacin. And then in the presence of the monitor, we're able to demonstrate that the drug was breaking up his AFib, and in fact, it had him in a paroxysmal pattern. So based on that, we could prove that he was in fact symptomatic from his arrhythmia and not just from being a little deconditioned, and offer him an ablation procedure. So here's the monitoring results that we get in the office, and imagine this data to help you guide your management of any one individual. He's got 35% AFib burden. We know his heart rates during those episodes of atrial fibrillation. We can see that he spends a lot of time above 100 beats a minute, so his rate control is not good. We can be assured the data is good quality because he's got these wonderful electrograms that the device is sensing. We can see the irregularity of the atrial fibrillation, so it's obvious it's the real arrhythmia. The device is detecting it appropriately. And then in the top graph, here's a histogram of when his episodes start. And it turns out almost 40% of his episodes are starting at 9 o'clock at night. And his wife says that's exactly when I lose him. He fades away, he becomes distant at 9 o'clock at night quite reliably. She's picked that up, it makes perfect sense to her. And we can demonstrate that you are truly symptomatic from your atrial fibrillation, and we're justified in being, really aggressive in your management. So we took this gentleman to ablation. Here is our electrical map of the left atrium. We've labeled the pulmonary veins, the left atrial appendage, so you get some sense of the chamber. And each of the red dots are where we've applied ablation energy to disconnect the pulmonary veins and to ablate other hot spots in the chamber that are contributing to his arrhythmia. So here's his ablation. Quite serendipitously, his episode of atrial fibrillation stopped during our procedure, and that was when we had the catheter ablating a hot spot anterior to the left atrial appendage. Quite by dumb luck, trying to eliminate these other structures contributing to the AFib, his arrhythmia stopped, and then with aggressive burst pacing in the atrium, isupril, no isupril, we couldn't get AFib started for him at all. His atria just would not support it after that final step in our ablation. And sure enough, that bodes very well for long-term success. Here is his monitor showing all of his AFib. You see high burden, occurring almost daily, 24 hours a day, days at a time. His ablation procedure occurs at the pink line, and for months subsequently, there's no atrial fibrillation at all. So we start with somebody who's actually sent for a pacemaker and an AV node ablation, and with the use of monitoring and an effective ablation strategy, we have somebody who doesn't have a pacemaker, his heart's completely intact, and he doesn't have any more atrial fibrillation, and feeling much better. So, a very satisfying result, and one that's becoming, representative of our experience with this arrhythmia, rather than the rare exception of success. So it's fun for us. Take the next slide. Have the next one, Cressa? Thanks. So, we do other rhythms, particularly in our elderly population. There's a large burden of atrial flutter. A lot of morbidity from atrial flutter. It's our simplest catheter ablation. It's a circuit running around the tricuspid valve on the right side, just hammering out a rhythm that keeps the heart out of rhythm, loss of AV synchrony. Patients are symptomatic, even if they don't appear overtly symptomatic. It's a very simple procedure. I believe everyone who has documented atrial flutter should at least be offered a catheter ablation procedure as a curative maneuver. And that's fine. There you just see on ECG, we all recognize these big classic flutter waves. And then in the electrophysiology lab on our catheters, there we see those flutter waves actually spinning around that atrial chamber, and helps us guide our procedure. Very common in our elderly population, particularly women, 5th, 6th, 7th, 8th decade, is AV node reentry tachycardia. I know there's quite a few people in Pendleton who have at least had this arrhythmia, probably still more who have, because we do get a fair number of referrals. And again, a very simple and effective ablation strategy for patients who have AVNRT. How do you know it's AVNRT? You'll never know for sure until you have them in the EP lab. So what we look for is narrow complex tachycardia, just a fast heart rate with the same QRS complex that you would see in normal sinus rhythm. In the EP lab, we can reinduce the tachycardia, prove the mechanism by which the heart's supporting that arrhythmia, and then offer an ablation procedure to cauterize a small region of tissue that's involved in that tachycardia circuit, goal to eliminate the circuit and render that patient arrhythmia free. So when we do this in the morning, we expect people to go home same day. And many of our patients do. Just have to lay flat for 4 hours afterwards while the vein insertion sites in your groin seal up. And then finally, atrial tachycardia. This is just a spot in your top chamber which behaves autonomously, can take off at rapid rates. This is a gentleman who we'd actually done a prior flutter ablation for, came into hospital, and his heart rate was always 100 to 110 beats a minute. Day, night, exercise, no exercise. He felt crummy, and the ECG looked like that was sort of a sinus rhythm P wave, but sort of the incessant nature without any physiologic modulation suggested this was something else, and indeed it proved to be an atrial tachycardia coming from the posterior right atrial wall, close to the sinus node, so the P wave would look similar, but clearly not the sinus node, and we were able to ablate him and give him his normal rhythm back. And finally, Wolff-Parkinson-White. It's frequently a condition of the pediatrics. This is one to look for in young people, particularly young males will have a predominance. This is a 26-year-old state trooper who would have debilitating supraventricular tachycardia. He'd literally be chasing bad guys and go into tachycardia and have to stop, so he'd lose the chase because his heart was racing. And we were able to ablate him with a left lateral accessory pathway. So here our catheters are crossing the wall of the heart into the left atrium. Our goal now is to get a catheter right on top of that bypass tract that's supporting that Wolff-Parkinson-White tachycardia, and to eliminate that bypass tract. They're a little bit rare, so it's always exciting for us when we see a Wolff-Parkinson-White. So we've done a few of these as well. several things more exotic, and I'm only starting to appreciate now how common these are in the general population, particularly in the elderly, is premature ventricular contractions. High burden to PVCs gives patients a pulse deficit. They have a pulse deficit because the PVC beat is not efficient, so they don't get much blood flow from it. So the PVC puts them in a low output state for which they can actually be really symptomatic. So here's a 90-year-old man. You can see he's in a bigeminal PVC pattern. On a Holter monitor, the burden is 40–50%. He actually has a low ejection fraction and a CRT device, so that resynchronizing pacemaker, only the PVC keeps interfering with it. So we brought him for an ablation procedure. And I'll have the next slide. Thank you. And this PVC, where is it coming from? It's coming from within his aortic valve. So retrograde around the aorta, catheter into the aortic valve. Within the valve cusps is where the site of origin of that PVC is. So here you can see how our computer map has drawn around the aortic arch, defined that valve bulb, and where you see the red dots are the site of successful ablation. If you put a catheter where a PVC is coming from, what you'll record at that local site is electrical activity starting there and starting to spread before the ECG takes off as the whole heart gets activated. So if you can record that very early electrical signal, 30 milliseconds or more before the onset of the QRS complex, you're really at ground zero for where that extra beat is coming from. You can ablate at that site and take care of that PVC. Really solve people's problems effectively. There is an echo image showing the ablation catheter within the coronary cusp as we zoom in on that spot where that PVC is coming from. There's some of the technology we have in the lab that we can use in conjunction with the mapping systems to really localize structures, know where our catheters are, perform these fairly complex procedures safely. So here you see the PVC. These are the extra beats, extra. I've circled the on button. That's when we start the ablation energy. And you can see that almost immediately that PVC is eliminated when you ablate at the correct spot and never to be seen again from within the coronary cusp. Here is another 62-year-old male, normal heart. He's got bothersome palpitations, 22% PVC burden by Holter monitoring. And his PVC was actually coming from a cardiac vein. So the venous system that runs on the outside of the heart can be a source of electrical instability. We can put our catheters into those veins, get on top of PVCs that are coming from the venous system. Just make sure you're not close enough to a coronary artery that you can give a person a heart attack by ablating at that spot, but prove you're in a safe spot, and you can really help people out. So take the next slide. Here we see the mapping catheter again. The gray bulb is the aortic valve. We've demonstrated where that structure is. The coronary sinus is that vein wrapping around the heart at the base, right along the AV groove. And we can put those catheters all the way out to the great cardiac vein at the summit, right at the top of your heart, and find that premature beat originating at that spot and effectively ablate from that location. And here we see again the PVC, ablation energy comes on, and within just several seconds of applying radio frequency energy, that PVC is gone for good. We've ablated PVCs coming from your papillary muscles within the left ventricle. So we have these muscle bundles that support the mitral valve in the left ventricle. That can be a source of electrical instability. Here we see our ablation catheter on the echo image. It's perched on the very top of that papillary muscle where that PVC was coming from, and ablation energy at that spot got rid of that extra beat. So these are really fun procedures for us because you can never be sure where the PVC is coming from, and going into the procedure, you just have to be prepared to put your catheter anywhere in the heart that you feel you need to. So it's a diagnostic dilemma. Something that we really enjoy doing, and I've found in private practice we really do quite a number of these. It was surprising to me. In 2013 we did 35 PVC ablations, which when you think about it is a little under 1 a week, which is, you know, more than I expected going into private practice. And I think a lot of people have benefited from that. So again, just to summarize, you guys have been great. We're here to assist you with your patients. We're here to offer the latest and greatest for your most common patients. The goal not to apply the technology to people, but to use technology to really benefit those people who are good candidates and can benefit from the services that we offer. We can help evaluate symptoms. We can help make diagnosis. We're all a little baffled by those unexplained falls, those blackouts, the irregularity, the symptoms of palpitations. We can help work through those things, help evaluate people, help with monitoring, help with medication therapy. We can perform device implantation, you know, the pacemakers, defibrillators, these new subcutaneous defibrillators, resynchronizing therapy for patients with heart failure, low ejection fraction, conduction system disease, and arrhythmia therapy and ablation. Importantly, for atrial fibrillation, there's a huge burden of symptomatic atrial fibrillation out there. There's a lot we can offer patients with atrial fibrillation. We're very happy to help out. And then for so many of the other common arrhythmias, I think it's important that we at least offer patients the opportunity to consider a catheter ablation procedure rather than having them believe that medical therapy is their only option. And so we'd be happy to discuss with you, discuss with them on an individual basis and find out what's really best for each individual. It's always our goal. So thank you very much for coming, for your attention. It's been fun, great questions. If there's any more discussion, be happy to entertain.
These subcutaneous pacemakers, do they work well with the morbidly obese population?
Yes, obesity is not a limitation to the subcutaneous ICD. Yeah, it's going to.
See our share.
Sorry?
See our share.
Of obese.
Yes.
Yeah. You know, the implant's a little bit, the implant's a little bit more challenging, but the ability of the device in that population is the same. Yeah.
And then you were talking about MRI safe pacemakers. How
Yeah.
do you know if they're MRI safe?
Well, there's pacemakers. So we know from some of the work out of Johns Hopkins that pacemakers can undergo ICDs. You just have to check them before and after. Pacemakers can undergo MRIs. Now we're getting labeling from the FDA from pacemakers that have been evaluated for MRI and are limited for MRI safety, formally studied and labeled as MRI conditional. So now you know that there's no contraindication. Yeah, we're not there with defibrillators, but pacemakers are really rounding the bases on that one, which is nice. So it's nice not to preclude someone, you know, right at the moment that you offer them a device. Those are great questions, really great. Any more discussion?
What's the cost of a implantable monitor, the paperclip one?
The paperclip monitor. The shelf price, as I understand it, $5,000 to the insurance company. And then what the patient's copay is, I'm not sure. Yeah. So, you know, I think about it. For AFib ablation, the insurance company could get billed $30,000, $40,000, $50,000. So to know that it works justifies it. Every ED visit is going to cost the hospital how much? If that loop recorder can help keep your patient out of the ED because you're able to have better control of their AFib, really know how effectively you're treating them. I think from a healthcare economics perspective, that's probably a good decision to implant. My sense is that since I've been using the monitors that I implant less pacemakers and less defibrillators because it takes guesswork out of the diagnostics and interestingly in a way that often biases you away from the device.
Well, a halter's probably $1,000.
Sorry?
A halter's probably $1,000.
$1,000 to do a halter.
Yeah, when all said and done.
Mm-hmm. Mm-hmm.
They should be okay with
Yeah, you'd think. You know, now you have the patient gets a transmitter that can sit on their bedside. It can interact with the loop recorder automatically every night, and within program parameters transmit data to us every night if it needs to.
For 3 years.
Yeah. So then there becomes data management issues. So it's nice to have a device lab that can accommodate that information. And if you have patients and you don't have the infrastructure to manage the data, we're happy to manage the data and send intermittent reports, that kind of thing. You know, all that can be worked out. I guess that might become part of the overhead going forward, is that we need to manage data. So that's an ongoing source of cost, I guess, beyond the implant. But in my mind, again, if it's keeping patients out of the emergency room, and if it's stopping them from having more expensive devices, and if it's letting you know that therapy is truly effective, I mean, I have to think this stuff in the end benefits healthcare economics.
What would you say the recurrence rate for AFib post-ablation would be, if there is one?
Yeah, so sort of it depends a little bit if your clinical pattern was paroxysmal before the procedure versus persistent. I think 3 to 5 year data says 80% effectiveness for paroxysmal, probably closer to 60% for persistent in terms of elimination of AF at those time points. What you can kind of promise your patient is that they'll almost certainly have less. The episodes they experience will be less intense, less symptomatic, and they'll be more likely to respond to antiarrhythmic meds than they were previously. The drugs are kind of up against the weaker enemy, so to speak. So for people who are really symptomatic, even that improvement can be enough to sell them on the procedure.
For people that do reoccur, you know, not all the time, but sometimes, will they have to be on blood thinners as well?
That's a great question. That's a great question. So a lot of people come seeking AFib ablation, goal to get off of blood thinners. The guidelines say continue to anticoagulation per CHADS or CHADS VAS score. Why? Because we can't, without monitoring at least, we can't know if there's asymptomatic recurrences occurring. Because your presentation for AFib will be different post-ablation. You probably may not recognize it. Even in very symptomatic people, studies have shown that there's a certain burden of AFib that is unrecognized even by those people who are really symptomatic. So post-ablation, because of asymptomatic recurrences, having the same stroke risk, the guideline is continue per CHAD score. For people who are just super motivated to get off their blood thinners, I'll sometimes strike a deal and say, as long as you have the loop recorder, and while it continues to show 0 AFib, I'll allow you to take the risk. You know, we'll say that's justified. But as soon as you have a significant recurrence, we really need you back on the blood thinner. So don't throw out your Xarelto. You know, we'll need you to go back on it as soon as there's a recurrence. And
Particular blood thinner these days?
I like. That's a good question. That's a good question.
Out there. I mean, I see so many of them.
I like, so in my mind, right now, Xarelto and Eliquis have the possibility of a reversal agent. So if someone comes in with a major bleed, like an intracranial hemorrhage, for example, and you want to reverse them right now, those are the two that have a potential for reversibility. Whereas at this moment, Pradax is not reversible, and the antidote may be coming, but it's not here yet. So that throws me towards the 10A inhibitors, which are Xarelto and Eliquis, rather than the direct thrombin inhibitor, which is Pradaxa. Between those two, Xarelto has more FDA indications at present. So it's indicated for non-valvular AFib, treatment and prophylaxis for DVT and PE, and also prophylaxis for hip and knee surgery. It was treated for, in AFib, it was investigated in a trial where the average CHAD score was like 3.5. So these were people with a lot of comorbidities in addition to their AFib, and it proved non-inferiority in that sicker population. Eliquis says it proves superiority, but in a less sick population. You know, average CHAD score was like 2. Xarelto has the once-day labeling. Eliquis has the twice-day labeling. I tend to favor Xarelto partly for that, and partly because if someone misses a dose or the dose is delayed, they'll be less through their therapeutic interval before they remember to take it again. So the chance of dropping to subtherapeutic, I think, is slightly smaller with Xarelto because of the once-daily dosing. So I tend to use Xarelto more in my practice. And perhaps that's because I got used to it before Eliquis became available.
Aren't you being a little over-compulsive about for AFib, stroke prophylaxis, missing a dose of Xarelto? I mean,
Well, then you're subtherapeutic.
yeah, but the 1 year risk for stroke in untreated non-valvular is only 3%.
Yeah.
So you get 1/365th of 3% is 0.01% per day.
Yeah.
So, I mean, we can afford to relax a little bit on this, can't we?
Yeah.
I mean, they go to
Right. The broader internist perspective is, yeah, I appreciate that, but it's like, with Coumadin, if you miss a dose, on average your INR will sag a little bit, but it probably won't fall out of therapeutic range, or it'll go slightly below. You won't completely go to zero. You have to think if you miss Xarelto for a day or the oral agents for a day, your INR is back to 1 effectively.
There's no rebound though with Xarelto.
No.
So, I mean, I every week I get requests from people with AFib for knee clearance for knee surgery, hip surgery, lumbar spine injections, and we routinely take people off their Xarelto or warfarin for 5 days.
Yes.
Xarelto for 48 hours.
Yes.
And I've never had a complication. Now,
Right.
I have thousands of patients in my pocket. But as a general internist, I can relax a little bit about being out of the therapeutic range.
Right.
Now, what is, just for our edification, what is the antidote for Xarelto and Eliquis?
So it is not FDA approved, but we all behave like it exists and works, and that's 4-factor PCC, prothrombin complex concentrate. So sits in your pharmacy as a powder, add water and stir, effective reversal within 20-30 minutes of application.
How about fresh frozen?
Our pharmacy doesn't have it.
Doesn't have it? I mean, you could have a dose or two you could have a dose or two. I think it's 5,000 a dose or something, but you're going to use it very rarely, and the shelf life is really good. So it's not like,
We'll ship up to you.
it's powder. So I think the shelf life is years for the powder, because you reconstitute it.
How often do you check their levels with Xarelto?
There's no level to check.
There's no level.
Yeah.
Okay, so you're talking about therapeutic levels, but
That's,
okay.
I guess I should say you just have to assume you're therapeutic if you take it.
Okay.
Yeah, and then if you miss it, you fall out of therapy.
I thought maybe I missed something.
No, sorry, I misspoke, really.
How about fresh frozen plasma for a bleed in the face of Xarelto therapy?
That's what they were recommending when they first detailed the drug.
Yes. I think you're going to get an improvement. Sorry?
I'll guarantee you it's under $5,000.
It's under $5,000. Right. My sense is it wouldn't be as good, but it's way better than nothing.
But that's what they were touting as their antidote when they first brought out the drug to us.
Oh, it was FF, okay.
The FFP.
For Xarelto.
Yes.
That's interesting. So our pharmacy has a few doses of the 4-factor PCC, or K-Centra, I think is the brand name. Again, that's off-label because the FDA has not approved that. There's a series in circulation, a small group of healthy volunteers where it effectively reversed. I used it once myself and bleeding stopped. A lady post-AFib ablation, I gave the first dose of Xarelto, full dose the night after. She had GI pathology, which I didn't appreciate, and she had a major GI bleed that night, probably from the stress of the procedure, and she needed 4 units to transfuse, and you know, she was actively bleeding, and we gave the 4-factor PCC, and at least it stopped, you know. So presumably it worked. That was my one, and that's my own personal experience with it. But I know major centers. I've asked the head of EP at Mount Sinai in New York, do you do AFib ablation on uninterrupted Xarelto? And more labs are. And he said, yeah, we do it because 4-factor PCC exists, and in the rare case where we may get into trouble, we have somewhere to go. So we're not that gutsy yet, but there's centers doing it, and they're acting as if it's an effective reversal agent. Yeah. Question?
Okay, your preference, Xarelto, Eliquis versus warfarin.
Xarelto, Eliquis, or warfarin?
Eliquis versus warfarin. How do you feel about warfarin?
How do I feel about warfarin? I mean, it protects you, you know, and it's cheap. And for people who are very stable on it, I don't encourage them to switch. It's vulnerable to changes in your diet, changes in your medication, you know, so those are concerns. I've had, you know, I can tell a story. I had a patient that I met for the first time on warfarin. I prescribed an antiarrhythmic propafenone. The patient went and had a fall, brought into hospital, CT scan showed intracranial hemorrhage. They thought it was most consistent with a routine hypertensive stroke. But his INR on presentation was 4.4, and he was always stable before, and RISK said, we're going to blame this on you starting propafenone and not arranging for intense INR follow-up, because we found a paper that propafenone is one of the 700 drugs that can affect warfarin, and this paper says it can increase it by 40%. And so, just so you know, it's your fault, you know, or you caused the high INR. You didn't cause the stroke and the bleed, but you caused the high INR, which probably made it worse. So, you know, that turns me off quickly about warfarin, and I prefer my patients to be off of it, because those things can happen, you know. Which never happens, and it's hard to get people into warfarin clinics and whatever, and you know. So, you know, when you see that happen, and you know the finger's kind of pointed, absolutely. But the shelf price is $300, so.
Well, when you consider the monitoring for INR when you're on warfarin, it should balance out for like insurance coverage.
Right.
However, Xarelto is paid out of Medicare Part D, and INR monitoring is paid out of Medicare Part A or B, I think it's B. So Part D insurer won't pay for it. Unless they're in a Medicare Advantage plan, in which they're globally responsible for costs A, B, C, and D, and they will pay for it. Or in their commercial insurance, and they will generally pay for it. If you write a prior auth which says the global cost of Xarelto is less than drug plus monitoring. At St. Anthony's, they're charging about $250 for the warfarin clinic.
Per time?
Per shot. That's right. That's for the finger stick. Okay.
And cities,
And you wonder why the cost of Medicare is so high. and
What
insurance
is the
rates.
reimbursement rate though?
Oh, it's about $12.
Okay.
I have no
They can
idea.
charge
No,
whatever they
no,
want.
it's $250, and since St. Anthony's is a critical access hospital, they get reimbursed on a cost plus basis. So it's $250 plus another $450 for the depreciation on the facility.
Gosh, I have a hard time swallowing that, but I'll take your word for it for now.
That's interesting.
You trying to make me feel guilty?
I hope I have.
That's
What
great.
makes the world go round? Now, in our office, we have people go to oh, yeah, and also the Coumadin Clinic, St. Anthony's, will not actually take care of anyone if they're sick. Meaning, if they're not unable to get into the hospital, or if they're in a nursing home, or if they're on
We should have mobile service. I agree with that. They should have mobile service.
well,
I agree with that.
you should.
I need,
Yes, you should. You should.
I agree
Are you
with
gonna
that.
get that fixed up?
I'll see what I can do. Duly noted.
I'll work on it.
Thank you.
Oh,
Yeah.
that's our office. That's my cell. If a provider wants to text me or call me, just call me.
Thank you.
No big deal. Thank you.